Good evening, everyone. I would like to begin by thanking the AIOS ARC for giving me the opportunity to speak on this topic, pediatric optic neuritis, current understanding. As we all know, pediatric optic neuritis is one of the most common diseases that we come across in ophthalmology clinics, and a lot has happened in the last decade towards the understanding of the condition. Therefore, I would like to cover this topic with certain specific objectives, such as to understand what is the current understanding about the etiology, what are the clinical and radiological clues to establishing the underlying diagnosis, current recommendations for workup, what are the new options in treatment, and what are the new diseases that are possibly going to come across in the spectrum of etiology. So to begin with, optic neuritis most commonly occurs secondary to demyelination. It could be an isolated phenomenon, which we call as clinically isolated syndrome, or as a part of associated CNS or systemic disease. The most common diseases that are associated in pediatric optic neuritis are multiple sclerosis, acute disseminated encephalomyelitis, neuromyelitis optica, and MOG-associated demyelinating disorders. Not infrequently in pediatric optic neuritis, it could occur secondary to a infection or vaccination, that is para-infectious or post-vaccination optic neuritis. Therefore, we should also keep these etiologies in our mind. Coming to the current understanding into etiology, a lot has been understood over last decade that a lot of patients in pediatric optic neuritis could be either MS or MOG-associated optic neuritis. This study by the PD group showed that in nearly 50% of patients, an underlying neuroinflammatory disorder was the final etiology. In descending order of frequency, it was MOG-associated optic neuritis, TED, multiple sclerosis, and NMO. Further, this study showed that an associated immunological diagnosis was associated with worse visual acuity at presentation. However, this study did not give us too much information on the clinical clues and the final outcomes of these patients. But it is important to distinguish these patients at presentation because of differences in terms of recurrences, visual outcomes, and neurological disability that we might see in these patients. So are there other clinical clues? There is a big study by Hypohen's group which looked at patients who have recurrent pediatric optic neuritis. And this study gave us some clues as to underlying differences between different etiologies. Coming first to differences between multiple sclerosis versus non-multiple sclerosis demyelinating disease, they found that patients with multiple sclerosis were more often females. They were more likely to be adolescents and young adults rather than young children. They never presented with edema, and they might present with optic neuritis and brainstem clinically isolated syndrome. Similarly, they found some important differences between NMO and MOG. They found that children with MOG-associated optic neuritis were younger. On contrary, patients with NMO tended to present with transverse myelitis and clinically isolated syndrome other than optic neuritis and transverse myelitis more often than MOG. Patients with MOG tended to have vomiting, nausea, weight loss, and area post-traumatic syndrome more often than MOG. And finally, patients with MOG-associated optic neuritis tended to have monophasic disseminated encephalomyelitis. In the current understanding, there are certain clues to the most common underlying neuroinflammatory syndrome, that is MOG-associated optic neuritis. These patients do tend to have prodromal symptoms, might have CNS dysfunction, new onset seizures, might present with area post-traumatic syndrome. They might have hemorrhages and the peripapillary area like shown in this figure, and they might have multifocal brainstem lesions on MRI. On an average, they tend to have good outcomes but might show recurrences. In our limited experience from LVPI, we noted that prior fever or prodromal episode was noted in nearly 50% of patients. A little less than 50% of patients had new onset neurological symptoms such as seizures, ataxic gait, or syncopal episode. Majority of these patients tended to have papillitis and had a bilateral presentation. In the presentation, we suspected MOG-associated optic neuritis due to prior mentioned features in nearly 50% of patients. And neuroimaging findings gave us other clues such as associated deep white matter involvement or large multifocal lesions in only 1/3 of the patients. And in our series, we observed that recurrences were observed in only 1/4 of the patients. So given this understanding, we should definitely proceed to establish the diagnosis. What should be the ideal workup? The ideal workup will include a neuroimaging, serology, as well as CSF analysis to establish final diagnosis. However, it could be economically challenging, especially for the young children, and therefore a lot of importance is given to neuroimaging. This is a landmark article by Dutra et al., who showed that the radiological differences could be very useful in differentiating between different neuroinflammatory syndromes. For example, in multiple sclerosis, usual optic nerve involvement is unilateral and involves short segments. There is usually no involvement of optic chiasm. Spinal cord involvement is in the white matter areas and tends to be discrete short lesions. The brain lesions are predominant in MS and can be in the periventricular area, pericallosal area, the subcortical white matters, as well as the white matter in the brainstem. In contrast, in NMO, the lesions can be bilateral, can be extensive, involving long segments of optic nerve, and can involve optic chiasm. Spinal cord lesions can involve white matter as well as the central canal, and these tend to be contiguous, involving more than 3 segments of the spine in the thoracic and lumbar areas, and there can be periependymal lesions. In MOG-associated optic neuritis, bilateral involvement is common, however, the chiasm is usually spared. LETM lesions can be seen in spinal cord but involve the sacrococcygeal area, and multiple white matter lesions can be seen, and especially involvement of area posterior can be seen in MOG-associated optic neuritis. So MRI can give us a lot of clues, and it should be the first line investigation. We should obtain MRI brain and orbits with contrast with stir and flare sequences to look for lesions in the brain and in the optic nerve, and MRI spine ideally in all, but especially in patients who have recurrent disease. The other thing that is very important is to obtain serology, especially for aquaporin and MOG antibodies in all patients. And CSF analysis, again, ideally should be done in all, but if the features are not suggestive of multiple sclerosis, it can be avoided in the first work. Coming briefly to the management, we usually follow modified ONTT protocol. Acute phase management is with the IV steroids for 3 to 5 days. And the chronic phase management depends on the final diagnosis. Clinically isolated syndrome, we do not require long-term steroids or immunomodulators, whereas NMS, NMO, and MOG do require definite treatment with specific agents. Especially in MS and NMO, there is high chance of recurrence and permanent disability. Therefore, all these patients should be given immunomodulators. In MOG-associated optic neuritis, it is understood that only 30% patients have recurrences. Therefore, it could be reserved for recurrent cases. There are many new drugs that are coming up in the management options. They include plasmapheresis, IVIG, monoclonal antibodies. This is beyond the scope of the current talk, but it is important to keep ourselves updated about this. And lastly, I would like to briefly share that in the last 1.5 years or so, since the onset of COVID pandemic, a lot of reports are coming up which suggest that COVID-19 might be associated with new onset or a recurrent optic neuritis. So we should always ask history of COVID-19 infection or vaccination, especially in adults, but we might be seeing it more often as the children get vaccinated. Thank you very much for a very patient hearing.
Thank you very much, Dr. SACHDEVA. Before Murli asks more questions, the basic question is, so that means that compared to MS, MOG is a more common presentation in children?
Good evening, Dr. Chitra and everyone. Yes.
I forgot to introduce you. all the confusion. You didn't know when you would join. Don't think you need to be introduced at all, I suppose. So my first
Nothing.
yeah.
No worries at all. I'm sorry, I got little delayed in OPD. So yes, that is very much correct. Experience from the Western countries as well as from India, from many of the centers, even in India, is coming up that MOG is the most common cause of optic neuritis in children. So it is becoming quite common, and previously possibly the testing was not easily available, therefore it could not be diagnosed. But many of these patients in our limited experience are like they do have symptoms like prior history of fever, and they might have prodromal symptoms, so therefore they might be thought to be as like classical idiopathic demyelinating optic neuritis or a clinically isolated syndrome. But now most of the people across India are also getting these testing done for all patients. Therefore, it is becoming quite evident that it is the most common kind of disease that is seen in children.
So Murli, can you take on?
Yes, madam. Yes, madam. So, I have a couple of questions, Dr. Virendra. One is that is the management of post-COVID optic neuritis any different from what we do for the clinically isolated syndrome or MS or MOG? I mean, is there any particular thing that we need to watch out and or be careful about?
I think it is still evolving, but with the limited experience that all of us have, is that majority of the patients are either showing a relapse of the previously known disease like neuromyelitis optica, MOG. So if that is the thing, it is just a trigger that is precipitating the relapse event. So in that case, you can go ahead with the same treatment. If it is not previously known, then to say that a definite diagnosis of COVID precipitating a new onset optic neuritis is a diagnosis of exclusion. You have to make sure. So you take definite history of infection, vaccination, and do a CSF analysis, which is not commonly done as part of routine workup. That is in the workup. As regards management, experience is giving mixed response, like patients who are showing a predisposition or temporal relation to COVID-19 infection, they are showing some improvement. Maybe it is little suboptimal than a classical demyelinating optic neuritis. And in relation to vaccination, if vaccination was the trigger, then these patients unfortunately are not showing good improvement. So whether time and more cases will tell that whether these patients need to be instituted other forms of treatment little early as compared to a demyelinating optic neuritis will be one important thought in my mind.
Dr. Virendra, I have a question.
Yes. Good evening, Dr. Mahesh.
Good evening, Dr. Virendra. So is it an established fact that MOG antibodies are more prevalent in COVID optic neuritis in children? Is it
no, I cannot say specifically for children, but in general, yes, MOG optic neuritis, MOG associated antibodies are more common in children. And if you are trying to say that in patients who have COVID, and if we look at adults and children both, whether MOG is quite common, I think it is still debatable because NMO, MOG, all are being reported.
Just one more question, like what is the role of long-term? We know that MOG is a recurrent disease dependent on steroids, and how do we spare steroids in children, and how safe are immunomodulators? Any experience, or do we refer to the neurologist? Right now we are referring to the neurologist. What is your experience?
Yes, we also are referring to neurologists and coordinating the care of such children along with the neurologist. They are preferring rituximab as a preferred first-line treatment. But again, there is a study that has come up in last year by the same group from UK, by Hakohen and colleagues. They suggested that even rituximab might precipitate little more relapses. So their practice is changing to using IVIG as the first line of treatment. So rituximab and IVIG are safe. Even mycophenolate mofetil can be pretty safe, though I have seen a few patients who are on mycophenolate mofetil and they had relapses. We had to shift to rituximab.